Hi, it's George Van Hare, and my task is to address the topic of this debate on the proponent side, and the topic is all tetralogy of Fallot patients need a preoperative electrophysiology study prior to pulmonary valve replacement. Here's my major disclosure, which is only that I am a medical officer at the FDA, and the agency would like me to remind you that all opinions expressed are personal and do not represent the official FDA policy. Now, it is a tradition in debates to tease or make fun of one's opponent in the debate, and I will just basically say that Andrew has been one of my best friends for many, many years, and I'll just put these two pictures up of Andrew and Alpay, along with Alpay's wife, at one of our PedirhythmX meetings in Istanbul, here with the Bosphorus as the backdrop, just so that you can see what you all may have missed if you haven't attended this meeting previously. So here's the argument. Sudden death due to ventricular tachycardia certainly happens in tetralogy patients, and particularly late after their repair. The anatomic substrate turns out to be pretty well understood in most patients. When patients come for pulmonary valve replacement, they are in fact more likely to have developed significant RV dilation due to chronic pulmonary insufficiency, and so therefore are at higher risk of developing VT. But unfortunately, pulmonary valve replacement does not address the substrate for VT, VF, or sudden cardiac death in this group of patients. Surgical PVR may eliminate catheter access to one or more important isthmuses. And finally, preoperative EPS and intraoperative ablation is in fact what they do in Leiden, and both Katja Zeppenfeld and Nico Bloom are pretty smart, in my opinion. And finally, I'd like to end up with getting on my soapbox a little bit and just make a comment about the fact that I believe that pediatric cardiologists should practice as if we expect our patients to become adults eventually. So just to remind you, I'm sure everyone knows that really electrophysiology study and tetralogy of flow really established our specialty. This is from 1977, first author Paul Gillette, one of the founders of our field. And this was the first recognition that sudden death was a problem in tetralogy and seemed to be closely related to both right bundle branch block and ventricular arrhythmias. So we've known for a long time that sudden death is associated with tetralogy. This is from a paper about 25 years ago from Nollert, which showed an overall 0.15% incidence of sudden death per year. But notably, the incidence of sudden death actually climbs quite a bit once you get beyond 25 years out. So this is really recognized as primarily a problem in adults with repaired tetralogy of flow. We also know that electrophysiology studies can identify ventricular tachycardia, and that this is tightly tied to the problem of sudden death in these patients. This is from Paul Carey's paper showing that a positive EPS for inducible monomorphic VT is an important risk factor or hazard for developing sudden death late after tetralogy of flow. And we all know that there are a number of identified risk factors through the years identified for the development of sudden cardiac death after repaired tetralogy of flow. Most importantly, I think, right ventricular hemodynamics. Early on, Tim Garson identified RV diastolic pressure and systolic pressure as important factors. Older age at surgery in multiple studies, it was really Kenzaka who first identified severe pulmonary regurgitation as an important risk factor. History of clinical VT, QRS duration, prolongation, and also, as I said before, Nollert showed years past surgery of greater than 10 being important. More recently, moderate to severe left ventricular dysfunction, not surprisingly, is associated with a risk for sudden death, and finally, the positive EPS as an issue. So what do we do typically with tetralogy of flow? The common approach is as follows. We typically think about PVR for patients with PI who are asymptomatic when they violate certain standards in terms of right ventricular size, either end diastolic volumes of greater than 160 mLs per meter squared or end systolic volumes of greater than 80. And that's determined by a cardiac MR. Of course, patients with symptoms attributable to pulmonary insufficiency may also be considered. We tend to reserve EPS for patients who are known to have VT or who've had syncope. We think about ICDs, obviously, as primary prevention, only for those who have had things like syncope and multiple risk factors for sudden death. We might do EPS and identify inducible VT, and then of course patients who've already survived a cardiac arrest are going to get an ICD for secondary prevention. And finally, we do ablation for those who have VT inducible at EPS, as well as those who have VT that leads to ICD therapy. The problem, of course, is that PVR does not really address the substrate or the risk for VT, VF, or sudden death. This is a paper from the group in Boston where they looked at their experience with PVR. In this group of patients, they found 77 tetralogy patients who had significant RV dilation who were undergoing PVR. And they matched it to 77 controls who also had tetralogy with similar levels of similar levels of RV dilation, but without PVR. What they found was that neither the incidence of VT, looking out to 10 years, or survival were any different between the two groups. So simply replacing the valve is not enough to protect this group of patients from sudden death due to ventricular tachycardia. A landmark paper by Katja Zemfeld really identified the anatomic substrate for tetralogy of Fallot VT. This is published in Circulation in 2007, and I was so impressed by this paper that I actually was happy to write the accompanying editorial. What Katja and her group did, and this actually took place at Brigham and Women's in Boston, was that they managed to map, basically doing substrate mapping for tetralogy patients using Cardo, identifying areas of scar as areas where there was low voltage and failure to capture using unipolar pacing. And what they did was identified a number of isthmuses that are surgically created as part of tetralogy of repair that mediate ventricular tachycardia in this group of patients. And they've numbered those isthmuses here, 1 through 4. And as you can see, isthmus 2 is from the lower end of the pulmonary valve down to the upper end of an outflow tract patch or incision. Isthmus 1 is from the patch to the tricuspid annulus. And isthmus 3, which is increasingly recognized as important, is from the upper end of the patch to the pulmonary artery, basically through the infundibular septum here. And isthmus 4 is here. And what they found was that in this initial paper was that they identified 15 circuits in 11 patients. They basically distributed through all those 4 isthmuses. They had initial success in eliminating inducibility of VT in all of their patients and recurrence in only 1 patient. Subsequently, I've recognized that, first of all, that isthmus number 3, which is the outlet septum, is increasingly important and is probably the most important isthmus in terms of mediating VT in this group of patients. They found that 4 of 28 repaired patients with tetralogy who had VT, and this is a subsequent series that they published, could not actually be ablated from the right ventricular side, even though one has access to the infundibular septum there. And so ablation at the outlet septal isthmus or in the region of the His was done. And they found difficulty due to septal hypertrophy, due to the presence of homograft, or the presence of a VST patch that interfered with their ability to access this region. And what they basically found was that these had to be approached through the left ventricle. And this is a figure from their paper with an ablation catheter placed in a pathologic specimen. And as you can see here, on the right side, this would be the approach to this region through the right ventricle, basically passing through the tricuspid valve and out to the outflow tract up against this fairly thick area of septum, and one can see that it might be difficult to achieve a transmural lesion, particularly if there's a patch or homograft in the way. And so in this group of patients, they had to approach this through a retrograde approach, coming through the aortic valve onto the left ventricular side of the septum. So the obvious thing is the question of whether some type of intraoperative ablation should be performed. If we can recognize what the isthmuses are, and we can identify patients who are at risk based on an EP study, and we've demonstrated our ability or our difficulties in reaching that area and effectively ablating it, perhaps intraoperative ablation is what it's called for. And so this is actually a series from Sandhu in 2018 that was published that involved 11 years of experience with this approach at 2 different centers. They had 70 tetralogy patients who needed pulmonary valve replacement, and roughly half of them had inducible sustained VT at preoperative EP study. They then underwent intraoperative cryoablation directed at the isthmuses that were identified. And then, because they were at risk and they weren't certain whether they had been cured, they all had ICD implants. Notably, they did not document conduction block intraoperatively. And what they found was that subsequently 21% of the patients who underwent this intraoperative cryoablation subsequently experienced therapies from their ICD. And so they suggested that these patients may actually require postoperative EP study to identify those that are at risk. Subsequently, Dr. Zappenfeld's group talked about the isthmus 3, which is that outlet septum, and the concept of potentially documenting intraoperatively whether this isthmus is actually blocked. Remembering that the paper I just showed basically failed to document bidirectional block. And so in this feasibility study that involved 7 patients with a VT substrate involving the outlet septum, the patients had their PVR performed with an open beating heart, and for the most part, homographs were used. And what they did was they identified the septum, the outlet septum. Then they placed pacing wires on either side, and in this picture from their paper, you can see that there are pacing wires on either side of that isthmus, and then they are using a multipolar grid catheter in order to characterize conduction across that isthmus. And what they do is they use this grid catheter, and each time they apply a minus 80-degree cryo lesion, they assess the effect and they continue cryoing until they have documented bidirectional block. It's too early to report on any long-term results from this approach, but this was basically a feasibility study just published this year. I should also note that that not all PVRs are performed using intraoperative approach. Many are actually done using transcatheter pulmonary valves, and here are diagrams of 3 different valves that are available. Basically the problem here is that when we place these valves in patients by transcatheter approach, we're basically using the same criteria that we would use for surgical PVR. These may be approached from the left side, but successful ablation will likely require transmural lesions. And the problem with these devices is that they actually cover up the outlet septum. So they eliminate your access to the outlet septum. In addition, it's common to see post-valve placement ventricular ectopy that's thought to be just based on mechanical irritation of the myocardium in that region. And although we know that this ventricular ectopy tends to settle down after about 6 months or so, it's actually pretty frequent. 3 different reports, the reports range from 6 to 16% of patients experiencing post-valve ectopy. And so the nightmare scenario, of course, is dropping a valve in one of these patients without knowing whether they have a substrate for VT. They then develop constant PVCs and a non-sustained ventricular tachycardia, and that eventually initiates an episode of sustained VT and VF in an unprotected patient. So here's my soapbox. I think that pediatric cardiologists should practice as if we expect our patients to become adults eventually. What do I mean by that? What I mean is that our goal should not just be to get our patients to adulthood, where our adult colleagues can take over. It should also be give them as long and as healthy a life as possible. And we need to recognize the decisions that we make in childhood echo into adulthood. We often find ourselves agonizing over timing of pulmonary valve replacement in patients with chronic PI. Is the right ventricle dilated severely enough to warrant that type of approach? But perhaps a different, more aggressive approach to avoiding the consequences of chronic PI, informed by attention to adult outcomes, is actually needed. So let me just summarize. Preoperative EPS and addressing the issues that are found makes biologic sense because we basically understand the substrate for most of the VT and tetralogy patients, and it seems like this should be addressable. Unfortunately, of course, long-term population-based outcomes data is not available. And even if these approaches are shown to be effective, we really don't know the number needed to treat to prevent sudden death, and of course have no idea about cost effectiveness. But I am absolutely thrilled that there are centers that are approaching this problem of sudden death and tetralogy in this way. I think we will learn a huge amount from their experience and what they report in terms of their outcomes. So I'll stop there and turn it over to Andrew for his rebuttal.